as well from the GI surgery side as well, so both of them can chime in. Okay, I want to be respectful to everybody's time. And first of all, thank you so much for joining for this Indo-US webinar series. Number one, first of all, Dr. Kennedy was supposed to join us, but his daughter got emergency surgery, and I got Dr. Bhuvan Giri. He chimed in at the last minute. So Dr. Giri, coming from the Ames Delhi originally, and then he immigrated. He did general surgery residency in Miami, and then he did his fellowship into GI Onco into Cleveland Clinic. I mean, he is outstanding surgeon, researcher, and he has presented he has published more than 40 plus publications into GI oncology field, and he is leading number of trials as well. So we're lucky to have Bhuvan as well here. From the speaker side, we have Dr. Viraj Lavingia. I mean, he's at Shelby Hospital. He's the head of all the oncology. The Shelby, they realize they need to, diversify in the oncology. So he is leading all the oncologists, oncosurgeon for more than 12 to 14 plus clinics all over Gujarat and outside Gujarat as well. Dr. Devang Basa, I mean, he comes with the experience of 25 plus years of experience in radiation oncology. I mean, there are so many people that I met. I wish I had met him during my recent visit to Ahmedabad, but I would definitely come to see him in coming days. But he is trained and worked with so many newcomers or the newbies, and as well as all the experienced radiation oncologists and training them. And we have Dr. Divesh Pathak as well. He's an oncosurgeon, and he is practicing at Advaita Hospital in Surat. And when I was going through his credentials, he comes from the same medical school I was trained back in the late 90s, like around 95, 98 time, but not that time. But he's a young champion in the oncosurgery there as well. And we have Dr. Kinder Shah as well here. He will also chime in from and he's a very dynamic oncosurgeon. He also does a lot of work in the GI field, and he keeps on traveling between India and US for learning, training, and partnering up with the things. So we have all the speakers. I will give the podium to Bhuvan. Dr. Giri, thank you so much for joining.
All right, thank you so much. Let me just share the windows, trying to see which window I should show my screen. Sorry, I'm using Google Meet for the first time, but let me see if I can update share screen. Okay. All right, let me share that screen. All right, are you able to see my screen? Yeah. All right. Great.
Yes.
Thank you.
Yes.
All right. Thank you so much, Dr. Shah, for the introduction. Just to reiterate, my name is Bhuvan Giri. I am originally from Bhutan. My partner, Dr. Kennedy, was supposed to present this, but he unfortunately had to get away for a family medical emergency. So I'm happy to present. Just get your opinion about some of these complex cases that I've seen in my practice here. I am a colorectal surgeon by training. So, if I say something that seems a little bit off in terms of medical oncology and radiation oncology, I appreciate you, feel free to correct me and see what your perspective is, because I'm sure we do things a little bit differently here. So I'm just going to start with something, there's an interesting case that I saw with a stage 4 rectal cancer. This patient required a lot of multidisciplinary care and care coordination. It's something that we don't do that often here as well in stage 4 rectal cancer. So let me see if I can start. So this gentleman is actually 45. He's 45 years old, so pretty young. he presented with some non-specific complaints of fatigue, and then he had a positive stool test. So then he underwent the workup for the fatigue and the blood per rectum. So essentially, the CAT scan outside showed that he had liver lesions. They were concerning for metastatic disease. He got a colonoscopy, which showed a rectal mass, so high rectal mass, and that biopsy confirmed moderately differentiated adenocarcinoma, right? And then he also got a PET scan that showed, bilobar metastatic disease and the rectal primary. So, and then obviously the next step was to get his liver mass biopsied, and that was consistent with colorectal primary. The microsatellite status was stable. So I just wanted to ask, probably just start with, Dr. Lavengia here. See, how would you approach this patient? This young patient with, microsatellite stable, stage 4 metastatic liver colorectal cancer.
Right. Thank you, Dr. Giri. Thank you, SecOpp, for having me here. So yes, this case would straight away go to MDT. Two things mainly would be the point of discussion. Liver disease. How much is the quantum of liver disease? There are certain, sometimes we can potentially convert them to operation versus there are sometimes, we are never going to operate them. Second thing is rectum. Where is the disease in the rectum? Is it low, mid, high? Because at our center, we tend to add some form of radiation if at all we're planning to later on do some loco-regional therapy for the rectal disease. So these two information is very vital before we move forward. Mm-hmm. Secondly, this patient is MSS, so the RAS and RAF testing and HER2, it's standard at our place. That would go right on day one. And based on that, most likely, assuming the surgeon says these are unresectable bilobar liver metastases, this patient would go on chemo, typically a triplet chemo, if it's a mutant. If it's wild type, we go doublet plus anti-EGFR.
Yep. I think those are all valid points, and I just want to mention the tumor was high rectum, so it's like around 9 centimeters from the anal verge. We didn't have originally MRI reports. So this was before I saw this patient, and we didn't have, unfortunately, he was at an outside hospital. We either lost the rectal MRI or we didn't have it on our revision, but it was on the colonoscopy and a high tumor. Right? And I don't know if I'm able to show it to you if this projects well, but he had innumerable bilobar liver metastatic disease. Right. So essentially, he had both sides. He did get the next generation, sequencing, as you mentioned, and these are the mutations that he had. Right. So he ended up getting. Sorry, I just heard something? Okay. All right. So I probably just go ahead with Dr. Pathak here. What would be your recommendation for this patient? If you're discussing him in like multidisciplinary tumor, doesn't really look like a surgical candidate at this point for us, right?
I think, do we have Dr. Pathak there? I think he...
Okay, no worries. So,
Dr. Kinner, you can chime in because you do this GI surgeries. Anything that you can flash on it?
Actually, yeah, can you hear me?
Yes.
Okay. So, since the last many years, I am doing only head and neck and breast cancers. But GI, definitely I get a lot of patients, and I try to at least participate in the whole treatment and the thinking process. And I do get references, so at least I'm actively involved in the treatment. Though because I don't do robotic surgery, so that is why I now I stopped doing these surgeries. Actually, the GI surgeries. I think in this patient, Dr. Bhuvan, is there any obstruction? Because it's 9 centimeters from the anal verge. So was it an obstructing lesion, or was it there was enough lumen?
Yeah, he was not obstructing. In fact, his symptoms were just mostly non-specific, some fatigue, and just the stool, the positive FOBD. But he was not symptomatic from the primary.
Correct. So I think recently I had one patient, an important patient with transverse colon cancer with bilobar metastasis, but there were 6 metastases in both the lobes totally. And I took him to a friend of mine. He did first we gave him chemotherapy. One of his, I don't remember, Viraj can help me, but which test was positive, as a result of which we gave him imitunab, which is a new drug, Viraj.
Colon?
Yeah, for colon. Ipilimumab?
Ipilimumab.
So which one?
Ipilimumab.
Yeah, ipilimumab. So I think we gave him that. He responded quite nicely. So robotic transverse colectomy was done, and a robotic hepatic artery infusion pump was inserted. He received chemotherapy through the hepatic artery pump. The lesions responded quite dramatically, and then he underwent wedge resection of all those lesions, 6 lesions. And after that, I think it's almost over a year, and he is fine. So again, but here in this patient, there is extensive bilateral bilobar metastasis. So, and the primary isn't that bad. So I think we need to address the liver mets, and therefore that liver mets, I think the best way to address it is through a hepatic artery infusion pump. But there is a time you can really blast the liver mets.
Right. Yeah, I think that is an excellent point, because his primary was not symptomatic. He's young, and even though it doesn't, like, the liver disease looked pretty extensive for any, at least attempt even at short interval local regional therapy with resection. So I think our HPB surgeons thought it'd be a good candidate for hepatic artery infusion pump placement. So he, after his initial systemic chemo, he got hepatic artery infusion pump and got FUDR inserted. Dr. Lavanya, anything different you do in terms of what kind of chemotherapy you'd give him, or the duration? Would you give him a little bit longer chemotherapy before you put him on a pump, or do you think that putting him in a pump would probably, would jeopardize or not really help you with controlling maybe other systemic disease, extrahepatic disease, and the primary that is still in place?
Yeah, great question. So first is the systemic option. So in patients who have mutation, RAS mutation mainly, in young fit patient, typically we do the Cairo 5 approach, which is triplet chemo, FOLFOXIRI plus BEV, and just like the tribe as well. That is what we would have done slightly differently. However, doublet plus BEV is an acceptable alternative. Secondly, we like to use at least 4 to 6 months of full chemotherapy. HAI, I'm not aware of any randomized study to be used in first-line metastatic colorectal cancer. I did fellowship in City of Hope with Dr. Marwan Faki. We did HAI, and back then we used to use Codman pumps. Now I think some chronic pumps. And secondly, we don't have FUDR in India. So just like the Gustavo Russi, they use oxaliplatin in there. So still heterogeneous, the HAI. In India, whatever HAI we have done or has gone through under my eyes has been in later lines or adjuvant to a high-risk liver resection. So let's say more than 4 or 5 liver mets has undergone good operation, that they're going to recur back in liver. And that's where we've done adjuvant HAI. But in first line, we have never done it. And I'm not sure there isn't any RCT for that.
Yeah. So this was interesting for me as well. He got into the pump pretty early, and essentially but unfortunately, this gentleman represented with an infection in his pump, and that's unfortunately quite a bad problem to have. So initially he got admitted. They tried to salvage it with antibiotics, but these are really hard and resistant infections to treat just when you have hardware in there already and patients on chemo. So he actually got the infusion pump explanted, and after that he got back into systemic chemo, recovered from that surgery, and got into he had I don't have the repeat images from his liver disease, but those were stable at that time. So that was like 4 months after. That's when I saw him, right? So that's when I saw him, and then he got evaluations. He's only had extra primary disease was only his liver disease. His PET scans were otherwise negative, so he got evaluated for liver transplant. And I just wanted to pause here and talk about, with all the organ shortages and all the things with the access to care that happens, even here, evaluating patients for liver transplant after, with metastatic stage 4 disease, with colorectal tumor. I know they've had good data in Europe, at least the European trials. Well, has there been any catching on in India for this? What has your experience been to both Dr. Lavingya and Dr. Pathak, if you've joined back?
Yeah, so transplant was an amazing study. It was an eye-opener. In fact, it was just wow. The graphs, the Kaplan-Meier's, we've never seen 5-year OS of 40-50%. If you show this liver picture of an MRI on day 1, there's no way I'm going to say 50% 5-year OS, right? But the selection of the cases were impeccable. They had to have at least 6 months to 12 months of excellent disease control on systemic treatment. That's a first-line treatment. Secondly, 0 amount of extrahepatic disease. So very recently, we transplanted one young woman, mid-30s. She had more than this, like 30, 35 lesions. But she was a doctor herself. And but she had excellent 1-year treatment on, started with FOLFOXIRI-Bev and then FOLFIRI-Bev. We removed oxaliplatin in view of neuropathy. And at the end of 1 year as well, she would continue. The CA completely went off to normal. The lesions looked, darkish, more necrotic over time on serial imaging. And that's when we took a risk and said, okay. And husband was kind enough. In India, 80 to 85% of liver transplants happen with live donors.
Live donor, yeah.
So that becomes easy in our country. I know, the surgeon which you were referring to, the Dutch guy, had to fight with the government, to put the patients on the list because that liver could help somebody else live. But, to give liver to these people, it has to be very calculated decision. But where in the countries where you have live donation liver, I think so the science is there. And if there is an appropriate patient, sure, we have started thinking about it now.
Yeah. So that is that's an excellent point. I think getting a live donor, that just changes the mathematics a little bit much more in favor. Here as well, there's a lot of deliberation when organs are at a premium. And we've just started doing, I think this is probably the second patient that we were talking about getting him on surgery. So then that's when he came to me. And then, the liver tumor board was decided that, he's a candidate if his extrahepatic primary can be resected. Okay. So then I'll probably, go back to Dr. Bhavsar see what would you do in this case, because we were now going to stage the primary. So this is basically a 9-centimeter tumor. It just looks like T1, T2, upper, straddling the peritoneal reflection cancer. And then on FlexTake is non-obstructive. But the only issue that there was, and I hope I probably didn't have this here, but he had a suspicious mesorectal lymph node. So Dr. Basu, in this case, would you go ahead? If it's an early high rectal tumor, would you recommend this patient get any radiation, or would you say just proceed straight to surgery?
So looking at the position of the disease, and it is non-obstructing with a very significant response. How is the response compared with the previously before chemo? Is there you are doing any MRI based or PET scan? They reported any response criteria?
So in this patient, unfortunately, so his initial workup was outside, and I don't think they ever got an MRI rectum on his workup. Mm-hmm. So we don't really know in terms of what his response has been. Okay. So that has been something, that was a little concerning for us as well. So we don't have a pre-treatment MRI for this patient. Okay. So, and then now we have, this after all this chemotherapy.
Okay. So if I don't have any detailing about the response criteria and looking at about the peritoneal reflection, I will straightforward tell my surgical colleague to look after the disease.
Right. Yeah. In this case, I think we discussed him in MDC as well. Okay. And then he was trying to get into the transplant list ASAP. So we talked about what would be the best way forward. And then since he had a suspicious mesorectal lymph node, which was indeterminate, and then we didn't have a pre-treatment MRI to get us the best shot of decreasing, trying to get a PCR on him, or at least trying to get a better response. We actually had him undergo short course radiation therapy.
Okay.
You said you would probably be more keen to have him undergo upfront surgical resection, but what has been your experience with, have you ever utilized short course, or would this be an acceptable indication for this kind of cases?
So Dr. Bhuvan, if you are not considering right now the liver disease, and I have some lesions are there in the upper part of the rectum, I will definitely prefer to go for the short course, and then we definitely submit for but looking at the volume in the systemic, or forget about the systemic disease, if it is in the lower part, I will definitely prefer to give at least the standard long course of the
Right. Yeah, I think there was a couple of timing issues for him as well. So we ended up getting, short course, and maybe going back to the surgeons in the group, if you patients, how long after radiation would you take these patients to surgery?
So are you talking about only short course? So you can immediately after the 10 to 15 days is the optimum time, or then whatever the recovery time. But if you are talking about the long course, we usually prefer to give at least 6 weeks.
Yes. Yeah. And what is the longest that people have waited, or people wait?
We have waited up to the TNT completion of the TNT also.
Yeah.
Today Today I have just recommended one patient to go undergo the surgery at the end of the 2 years.
Mm-hmm.
He has opted for the close observation, but now at the end of the 2 years, 2023, he was treated, and now he has a small recurrence is there. So he's undergoing the PET scan and MRI right now. So once he will get the non-metastatic workup is clear, he will definitely go for the surgery. He was treated in the month of November 23.
Right. Wow. Yeah, that's been a long. Yeah. So I've seen that mostly, I think, waiting 12 weeks after this just starts, the pelvis starts showing signs of all this fibrosis, and then the dissection becomes a little bit longer. And I think
what are the challenges? I'm not a surgeon, but whatever my interaction with the surgical colleagues, if anything, they are operating after 8 to 12 weeks or after 12 to 14 weeks, they are finding some more planes to be very difficulties they find because of the beginning of the fibrosis. That usually start after the week 12, and anything beyond that, longer the duration, then maybe the more adhesion. But because of the very limited and the very high end of the techniques you use, so whatever we see the previous era, the skin changes and all this thing is gone. But to mesorectum portions, they usually disturb them a lot.
Yeah. So the TME dissection, the total mesorectal excision dissection, becomes pretty difficult after, I think, 12 to 14 weeks. But in this case, he underwent surgery within the week after getting short course radiation therapy, and then he underwent a robotic LAR. He got a diverting loop ileostomy after that, and this is the pathology back. So Dr. Lavingio, would you do anything in this case, and anything different in terms of now that the pathology is back? Now, how would your chemotherapy be different, or would it be any different once he's recovering from the surgery and he's all clear for chemotherapy?
Yeah. So regarding this case, where patient has mild overextensive liver disease, we would have gone short course or no short course, but a minimally invasive LAR. And the histopathology really does not matter as long as there is an R0 resection, because the goal was to remove the primary and make the patient ready for getting the liver. And if that is still delayed, we would just continue FOLFIRI or FOLFOXIRI after 8 to 12 doses, and just FOLFIRI until we know, okay, liver is ready. We got the liver, and we would give at least 3 to 4 weeks of washout of chemotherapy, and then the liver surgeons do their thing.
Nice. Yeah. So I think he ended up going back on FOLFIRI. And then unfortunately, the last time I saw him, he actually developed some lung mets. So he has some suspicious lung nodules. So then now his transplant, course is on hold. So that just brings back to, the point that Dr. Lavingio, you were making about, how these patients need to be super selective. And most of the recurrences now, the lung is the second most common with these patients, obviously, when the liver's out. So I think we're probably going to start waiting a little bit more than just 6 months. This patient probably went in a little bit earlier than I think what we're going to try. We have a few other patients coming in, but I think we'll probably wait at least a year of stable disease before, we resect the primary, because now you resect the primary, you have the ileostomy, then you have interruption in chemotherapy. And then again, you don't have optimum systemic control. And if you have a complication, that complicates things again. So that was an important learning case for me. And it was very very educational for me as well. Thank you so much for all your input. I think if anybody has any comments, we can pause for that. Otherwise, I can go in a very short case in some rectal cancer in IBD patients, mostly a little bit more colorectal.
So before we move to the next case, what I have the comments here. So what Dr. Viraj was telling, we same agree with that. At least you should wait some few time before you take any major decision of changing the major surgical or the changing the treatment modality, right? So that part, what we learned from this previous case, that we have to give some enough breathing time in between for these types of the high volume metastatic disease, right?
Yeah. I completely agree with that. I think the timing part becomes pretty important.
Yeah. Go ahead.
All right.
Yeah.
Okay, this is someone that I saw in clinic, and from essentially, this is again, somehow I can put their ages, but this is a 72-year-old gentleman. He's had a diagnosis of ulcerative colitis. That was a long-standing IBD. And essentially, was controlled on steroids, some ASA compounds for a while, eventually ended up being on vedolizumab, is the integrin inhibitor, and he was having sustained remission on vedolizumab for the last 8-9 years. So not a lot of inflammation in the colon, but the concerning thing was that he's had, in November of 2023, he had high-grade dysplasia at 25 centimeters. He has some other low-grade dysplasias, multifocal. Initially had a chromoendoscopy, which didn't show any dysplasia. But then on repeat, in a short interval, he got a new flat lesion that was only identified at 15 centimeters. And the biopsy was, poorly differentiated adenocarcinoma with signet ring features, right? So I just wanted to go back to the panel and see, how would you evaluate and counsel this patient? For example, what will be your initial workup? What are the salient points that you're thinking of? And what helps you decide in terms of if they land up in your clinic? What would be your recommendation for these patients?
Yeah, so I'll take it, Dr. Giri.
Yeah. Yes, absolutely.
Right. So yes, elderly patient with new onset rectal disease in background of UC. We would want to do local staging with an MR, do CT thorax with margin down, so we can take look at liver as well. Distant metastases, to look for distant metastases. Although we do MSI for everyone, if there was no UC, that's the first test I wanted to do. But even if this patient is MSI high, we're not going to put him on any IO. We're not going to take that risk. But yes, MR, no rectal lesion. Yeah, great. So this looks very early T1 and CT normal. So this would straight away go to our colorectal guys and do the TATME or transanal something without having to operate from the abdomen. So something like that could be done here, or just plain. But because there's a signet ring, one would be very scared for doing just the snare. But some procedure endoscopically or endoluminally would be very appropriate for this gentleman.
Right. Yeah, that is an excellent point. I think that because of his age, so the first thought that I had was, is there something that is, you can barely even see it. So maybe it's just amenable to just, a transanal excision, right? It's like 15 centimeters, so it's still amenable. And depending on if it's anterior, posterior, you can, make the argument that you could just do a full thickness excision and then close. So that would probably be a good choice in him. I think the only thing, so as it's a stage 1 disease, so we talked about what our next stop. So anyways, I think in this case, if local staging, maybe Dr. Pastor, if I'll probably take you up for this and see if the patient had like more extensive disease, had like a mesorectal lymph node positive disease, would you do anything different for these IBD patients as your threshold? If they already have inflammation or they have history of inflammation and colitis, how would you approach these patients? And if they have locally advanced disease, or high risk in disease, or anything indicating that they may benefit from radiation, what's been your experience?
So basically, we have the very clear-cut reservation to treat these types of the inflammatory bowel disease. We'll have all the MDT discussion will go towards in that direction. Is there any way, because in this case, from the 15 centimeter is very high lesion, so you can definitely omit the radiation. If by chance it is a very high volume disease and in the lower part of the portion, or in the upper part with a very high mesorectal nodules or the lymph nodes metastasis is seen. In that particular selected cases, we have to explain what are the benefits versus what are the late sequelae. Because anyway you are not going to achieve if you are in the upper part, you are giving without any mesorectal disease and T3 lesion. So we'll say upfront go for the surgery, whatever the chemotherapy protocol we have to follow, and that we have to advise to the MDP majority of time.
Yeah. I think that's an excellent point. We were a little nervous with all the colitis that he had, and thankfully he had only, local disease. I mean, you couldn't even see it on MRI. So we discussed surgical options for him, and these were, transanal or, just section or transanal surgery was essentially a little bit higher up, but then you have a lot of this. So if you go back to his biopsy and surveillance, you already had high-grade dysplasia at a different area, and he also had, other areas of dysplasia in his other scope. So he's had a lot of dysplasia, and even though his colitis was well controlled, I think his all of his mucosa was at risk, right? And given that this was almost like an invisible dysplasia, even though you could see in the chromoendoscopy, there was questions about, is he a good candidate for taking all of his colon out, getting a pouch, giving a J pouch versus just doing the minimal thing possible, either a transanal or a local low anterior resection on him. So any thoughts in terms of if we have, if any surgeons here or any, GI surgeons, what would their discussion point be, and, what are the factors that they would take into account for this patient? I have to say that he was a 72, but he was, driving tractors, working in the farm. His sphincter tone was excellent. He essentially his rectum looked fine as well. So, even though you have colitis, IBD diagnosis, he didn't have active inflammation. So one could make the argument that you can make an anastomosis in the inflamed rectum, even though that places him probably at a higher risk than giving him an ileostomy or even a pouch. So some of the things that we talked about was just his age and whether, he'd be a good candidate for a J pouch. And then, but the thing that was really driving the care in this case was just mostly that he had a lot of at-risk mucosa and the history of dysplasia and pretty, bad signet ring pathology and aggressive features. So eventually he ended up getting, So eventually it ended up getting a pouch and he did well. The pathology was just PT1, N0, and essentially he's just going to be on pouchoscopy surveillance for after that. And he's been having good pouch function. So that was something. The other thing that I think we talk about in these patients, and I don't know if anybody wants to chime in, would be, doing an even more aggressive pouch in terms of taking all of his anal transition zone out and giving him a hands-on J pouch so that there's no at-risk mucosa, because the stapled J pouch will still leave a little bit of mucosa at risk where you're securing your distal staple. But anyways, he was, with his age and everything, we thought it would probably not be a good idea to give him a full-scale mucosectomy. So he ended up just getting a pouch. So that actually essentially is the end of my presentation, but I'm happy to take in any comments. I'll try to see if I can pause this.
We have
I
Dr.
have
join as well.
Yeah, just one comment from me.
Yes.
Yeah, I have the experience of treating one case. He has undergone for the upper rectal disease. He has undergone the LAR. He has undergone the LAR. Then whatever the remaining portion was there, at the end of the 5 years or maybe beginning of the 6 year, he has developed the disease, whatever the remaining rectum was there. And it was the adenocarcinoma and the same like the signet ring. And they were so badly behaving. And he presented with the infiltration of the posterior part of the prostate also. So that person I still remember by few odd numbers of the cases we have treated till today. So that person was there after the surgery. He was very long, almost same history of 20 years of the ulcerative colitis was there. And he was treated with all the concern. But somehow he has tolerated well and ultimately he has undergone the APR.
Dr. Bhuvan, we can't hear you.
Bhuvan, you are mute.
Oh, sorry. Yeah. Yeah. So I was just saying, yeah, the signet cells are always very aggressive and they always make me nervous in terms of whenever I'm trying to get my margins and, follow up of these patients.
Okay. Do we have Dr. Hitesh Chawda join for a few minutes? If he's there, he does fantastic job in the GI surgeries. Would like to have his comment if he's there. But otherwise, anybody has any questions for Dr. Bhuvan, for Dr. Viraj, and Dr. Bhavsar? Okay. No, thank you so much, everybody here, for joining. I mean, it's perfect. Like 45 minutes is more than enough these days for our attention span in the world of the 30 seconds real world, Thank you so much. Thank you for Dr. Kinner for joining from New York here, representing India here in US as well. I would like to invite, just thank you note to Zoetic Pharma, Dinkaran. Again, no financial conflicts anywhere. They are helping us to reach out to all the physicians all over India, oncologists, for spreading the word about the webinar, and they were able to join. Dinkaran, I would like to say thank you to you, and if you can say a word to us.
Hi, good evening, sir. Actually, Dinakaran sir is traveling somewhere, so he might not be able to give you the thanking note. But my name is Ketan Soni. I'm working as a product executive. So I would like to thank all of you to being here and sharing all of these cases with us. And hopefully we'll meet in future as well. So thank you very much. And this is a vote of thanks from Zoetic as well.
Okay. Thank you, Dr. Giri, for joining with such a short notice. Thank you, Dr. Viraj. Thank you, Dr. Bhavsar. Thank you, Dr. Kinner. I appreciate it for all of your help and spreading the knowledge. I appreciate it. Thank you.
All right. Thank you, Dr. Thank you.
Thanks, everybody. Thank you, everybody.
And I think thank you, Ashish, for taking up this initiative. I think it's going to be a really nice initiative and a win-win for all, actually. So it's cool.
Thank you. We will continue this more often. We are doing once in a month, but hopefully in the future, under leaders like you guys in India, we can partner up. You guys take a lead and we bring the panelists from here and we can do more often this type of thing. Okay. Thank you all.
Okay.
Thank you. Bye.